Okay, I would like to introduce everybody to today's speaker, Scott Goodspeed. Scott is the Principal and Vice President of iVantage Health Analytics in Portland, Maine. Scott has been President and CEO of 4 hospitals in 3 different states. He has deep industry experience and a national reputation in governance. He's a nationally recognized speaker who has authored and delivered over 100 presentations to various professional and healthcare organizations. Scott has published books and articles on the topics of governance, balanced scorecards, and strategy. He is a member of the University of Minnesota Alumni Association and a senior fellow of the American Leadership Forum. He served on over 20 boards of directors and received his doctorate in health administration and leadership from the University of South Carolina. His dissertation was titled The Balanced Scorecard, Translating Strategy into Action. His master's degree in hospital administration was received from the University of Minnesota, and his bachelor degree in administration of healthcare services from Ithaca College in New York. So now I'm going to turn it over to Scott to start his presentation, Competing on Analytics, Using Metrics to Drive Performance.
Thank you, Leslie. The title of the presentation is Competing on Analytics, Using Metrics to Drive Performance, and we're going to talk about 3 kind of major categories there. First, we're going to talk about a study that iVantage Health Analytics just completed about 3 weeks ago. It's available on our website, but I can tell you that it has already made its way through Congress, and for small community hospitals, there's some very good news, and I'll just share the highlights. And I believe you all received a copy of that. And then we're going to talk about how you can improve performance in your own organization. Then we're going to talk about how any number of small community hospitals come together in either state or regional networks to improve performance. I'll share with you 5 or 6 case studies. They're all blinded, but all of the numbers are real. You may recognize some of the states, but we'll talk about how these organizations came together to improve performance, and we'll talk about kind of the specifics of what they did. And then, as I finish up, we'll talk about metrics and how you can use those to drive performance. As I go through the presentation, you'll see reference to a number of handouts. For example, there's a sample strategy execution agenda. There's a sample retreat agenda. There's a metrics document that we find is used by critical access hospitals and small rural hospitals. And once we get finished this webinar, Leslie will send you all of those materials. So when you hear me reference those, you don't have those today, but you'll receive those. I'm also happy to take any questions along the way. My sense is I'll probably go 50 to 60 minutes. If you want to ask questions as we go, that's okay. We're scheduled to go an hour and a half, and I have an hour and a half allotted to this. I'm getting on a plane to Chicago at about 4 o'clock, but I have plenty of time to get there. So let's go through the presentation. We'll talk about the performance-based, the national assessment we just completed April 25th. We'll talk about how you can use metrics to drive hospital performance. As importantly, we'll talk about how you can create networks among rural hospitals and how those networks can improve performance. So here's an overview of the topics I'm going to be covering. I'm not going to go through each one of these, but kind of the large categories. We'll talk about some national research. We'll talk about hospital strategy, how you can design and complete a strategic plan within 45 to 60 days, because we have hospitals that are doing that. And then we'll talk about how to create a network with other rural hospitals and how those networks improve collective performance among the hospitals. And then I'll finish up with a little bit of a discussion on what's a strong rural hospital. This slide is actually a picture of the perfect storm over New England, and the kind of the highlights just talk about, and you all know this, is that the healthcare environment is more complex with healthcare reform. But as I travel across the United States, I'm also hearing a little bit of confusion about accountable care organizations and what's the role of the rural hospital. And if any of you read Modern Healthcare Hospitals magazine, you heard that community health systems and some of the larger for-profits are actually going to stand on the sidelines and see how the nonprofits do in terms of these accountable care organizations. But here's some of the research that I conducted in 1999. It resulted in a book which you can see here, published by American Hospital Association, and I updated the research in 2005. But I had a research assistant, and I had funding from Modern Healthcare and the Governance Institute. And I asked my research assistant, after we went through all of the data and all of the analytics, just tell me what this means. I was running a hospital at a time, and I said, from a CEO perspective, what did we find? What were the key things? And he said to me, Scott, we basically found 4 things. These 52 hospitals that seem to outperform the others in the United States ask 4 simple questions, and they act on them. First, they ask, where are we today? Do we really understand the market that we're in, the relationship with the medical staff, and have a very keen and good understanding of their current reality? Second, they ask themselves, where should we be tomorrow? That's preferred future, and they're looking out typically 3, 4, and 5 years. The third question they ask is, how shall we get there? Meaning, what kinds of support systems, infrastructure, resources, capital do we need to get there? And the final thing that they were asking in 1999 is, in fact, are we getting there? So they had a system in place to monitor performance. In 2005, we updated the data and the research, and we found the first 4 things were absolutely in good stead. But the fifth thing that we culled out of the data was a question about culture. And does the current culture support not only our strategy, but execution of strategy? And I'm not going to go into it today, but those organizations that we resurveyed, we found what we characterize and what they characterize as a constructive culture, and there's a way of measuring that, there's a way of defining it. And it seems like those organizations are better at execution of strategy, achieving their objectives. When you link their cultural style with patient safety and quality, there's a direct correlation. So those are the 5 big findings out of that first book, and then some of the updated research in 2005. This is the national study that we just completed April 25th. The purpose was to look at the performance of rural hospitals relative to the urban counterparts across the United States. We did that using the latest Medicare shared savings data file. And if you look at the count of Medicare beneficiaries that we use to do the analysis, when we look at Part A, so that's the hospital insurance, there were almost 35 million Medicare beneficiaries that we analyzed. On the Part B side, there were about almost 32 million Medicare beneficiaries, and regardless of the beneficiary type, the percentage of rural contacts, if you will, was just about 23 to 24%. The definition that we used for rural versus urban was is the industry standard that came out of the Office of Management and Budget. So it was a fairly significant study, and you've all got a copy of it. But here are the highlights, and this is I think this is good news for those of us that lead rural hospitals. The is an annual savings to Medicare alone. If the average cost per urban beneficiary were equal to the average cost per rural beneficiary. Significant savings in rural health care. The good news is that we know a lot of this data in the last month because as some of the legislation tracks through Congress now, we understand and know that there are some potential cuts to critical access hospitals and rural hospitals, which provide access to care that the urban counterparts generally don't. The second finding is that there's an approximately $2.2 billion in an annual cost differential or savings that occurred in 2010 because the average cost per rural beneficiary was 3.7% less, okay, than the urban counterparts. And then the other finding that we found is about $9.4 billion per year is the existing and potential differential between Medicare beneficiary payments for rural versus urban hospitals, meaning that if all urban populations could be treated at the rural equivalent, significant opportunities for savings. When you look at per capita inpatient hospital services for rural beneficiaries, it's 2% less costly than the urban counterparts on a per capita physician service payment. Rural hospitals are just about 18% less costly. The only difference we find in terms of a service that's more costly as we look at per capita outpatient service payments for rural beneficiaries, they're about 14% more costly than payments for urban beneficiaries. And that's the only distinction we found on the finance side. When we looked at all of the Medicare beneficiaries and hospital performance findings, we found neither urban nor or rural, the cohort dominates performance across any of the process of care measures, be they pneumonia, heart failure, AMI, and then there was no significant performance variation on 30-day readmission rates at the benchmark level for the two hospital study groups. But what we did find is rural hospital performance on HCAHPS, patient experience survey measures, is better than the urban hospitals. And then finally, when we examined all of the Medicare cost reports, for 3 of the 4 price and cost efficiency measures that we looked at, rural hospital performance is better than urban hospitals. So one of my suggestions in the face of strategy and metrics, it's a national study. It's based on empirical data, and the definitions are well understood and well defined. And this is a document you may want to share not only at the state level but within your organizations at the board level, because there's very good news for small community hospitals. When we looked at national data as it relates to performance in the emergency department, the mean total wait time in a rural emergency department is about half as the wait in our urban counterparts. It's 98 minutes versus 247 minutes. And we'll show you some of the national benchmark data that is coming out of this study, the Advantage Health Analytics study. We'll show you the benchmarks from nations. And when I share those with you, you'll see significant benefit of being treated in a rural emergency department. And then when we looked at mean wait time to a physician in the rural environments, it's nearly 2 times less than the urban counterpart at 29 versus 56 minutes. And then finally, more than 50% of all the emergency department visits, and when we looked at just critical access hospitals, were categorized as low acuity. When we have been presenting this in the last month nationally, you know, a lot of the comments we hear is that this is very good news in terms of what's going on in rural healthcare in the United States. We're a smaller percentage of the healthcare budget, and if this is good news, why are we faced with some potential and significant cuts or even risk for a cost-based reimbursement. But let me keep going, but if you have questions along the way, I'm more than happy. But just to reference the study, we also have data on all of the states. So you can look at the numbers of Medicare beneficiaries in the state. You can compare how well you do with some of the other states on the indicators I just spoke about. So let me shift gears a little bit. That's a national perspective. Good news. I want to talk about how rural hospital strategy has changed over the last about the last 6 years. When I started traveling across the United States and working almost exclusively with small community hospitals, and we talked about a market assessment and how we gain market share, how we grow revenue, how we form an affiliation or a collaborative relationship with a larger community hospital. Most of the thinking was linear at the time. The thought was, how can we incrementally do a little bit better, grow outpatients revenue, maybe some of the clinical services, little at a time, and let's improve what we do over the next couple of years. I'd say 3 or 4 years ago, talking to the CEOs, executive teams, medical staff, leadership, started to hear about this strategic management system. And while strategy is what we need to be doing, we really have to better link it to operations. So everybody in the organization at the employee level not only understands where we're going to be in the next 3 years, but they also understand what they contribute to it. And then more recently, I'd say the last 18 to 24 months, I'm hearing CEOs at some of these rural hospitals that we've been working with talk about how we need to be strategy focused, how the discipline has to be a focus on metrics. We can make some good changes to our own organization, but maybe we can benefit if we work together with similar-sized community hospitals to improve. I'm also hearing more discussion about organization culture and what that means to strategy execution. I'm seeing more measurement of culture in the last 18 months. I'm hearing more conversations about what's being described to me as a constructive culture versus an aggressive kind of culture or a defensive kind of culture style. And then the other 2 things that I'm hearing in this change framework is now that we know strategically what's relevant to the organization, maybe those are the things we should be talking about in the boardroom, and those are the things we should be talking about at our executive management team as well as department director meetings. And then finally, I'm hearing that strategy drives budget. Budget doesn't drive budget. So a little bit of a framework, some differences over the last 5 or 6 years. Couple of the CEOs asked if I could show this pictorially, what a typical well thought out strategy, development, execution process looks like. And what I'm hearing in the field is if we think of strategy as 100%, about 25% of the time of that 100 is spent on a disciplined analysis, externally looking at the service area, looking at the demographics, performing what we call a market assessment, but also spending some amount of time doing a cultural assessment. So let's understand the style of the organization, whether it's going to help us execute the strategy or whether it may hinder execution of the strategy. And then the third thing the small community hospitals are doing is also having somebody come in, and it could be somebody from a local chamber or a local CEO or somebody from a university that's a very good facilitator, meet with members of the board, the executive team, medical staff leadership. Often there's an employee focus group, and let's understand what their collective best thinking is of where the organization should be in the next 3 years. So that's the kind of disciplined analysis prior to development of the strategic plan. The second 25% of the time is actually spent on strategy formulation. So once we understand the data and we understand qualitatively what's going on through the interviews, let's begin to think through where are the opportunities, strategically what's important, and you can see some of the strategic themes listed there. And then there typically is a drafting of the strategic plan. What I typically see is maybe 20 to 25 tables of key analytics and metrics, and you'll actually receive a copy of a strategic planning template that Leslie will send to you. Once the strategic plan is drafted, then there's a equal amount of time on the strategy execution side, and I will be sharing with you a strategy execution workshop, and how you involve and engage not only the executive management team, but probably more importantly, or as important as the supervisors and the department directors. But the key, as it says here, is the development of the metrics so we know what it is we're going to measure, but also having the discipline of stating responsibilities, time frames, and designating what the action is. And then I'd say the final 25% of the time in this process is actually let's monitor implementation or execution of the strategic plan. Let's do it at the board level, and let's do it at our management meetings. A group of CEOs shared with me when we sat down and we were talking about this, and they said, well, Scott, it's not that perfect. And they use this term. It's a continuous dynamic process. It's something we do, some said annually, some said we do this quarterly in terms of making adjustments, but given what's going on in the healthcare environment, there also is a disruptive process here. So we've got to understand the changes in Washington. We've got to understand what's going on with Medicaid in our own state, and legislatively what's going on in our own state. So there can be a little bit of this disruptive process where we've got to make adjustments along the way. These are the 5 things that I hear rural hospitals talk about when they get into a dialogue about what it means to be strategy focused, and these are the 5 things that they focus on. The first thing that I find is they have the ability to translate mission, vision, values, and objectives into action, and they use that by setting very specific initiatives with due dates, accountability, but they also have a system in place to monitor their performance, and that's the scorecard. The second thing I hear about is if you're going to be strategy focused, it's dependent upon executive leadership, where the CEO views him or herself as the sponsor driving strategy over the next. You talk to them about how they roll out their strategic plan. They talk about a performance culture. They talk about accountability at the employee level, and employees begin to reframe or think through how they deliver care or what their job is, and put it in a broader context. The third thing that these rural hospitals create is alignment within. So if you have a discussion with the department directors and talk about, tell me where the organization's going in the next 3 years and how does it do it, there seems to be a sole focus on delivery of care, patients, so you don't hear about individual silos. The emergency department, radiology, they seem to break down those kinds of barriers. The fourth thing that these rural hospitals focus on is they say strategy is everybody's job. And so not only are their presentations at the employee level related to strategy, but that's an ongoing process. And then finally, the other thing that these rural hospitals do to embed strategy is they link it to their budget. So strategy drives the budget. They link it to their board and management meetings, and then typically they have monthly or at a minimum quarterly scorecard reviews, so they can share organization-wide and lots of times within the community the progress that the organization is making. This is how rural hospitals develop and create their strategic plan in 45 to 60 days. And we've worked with a number of organizations and heard of a number of organizations that have done this. The first step is the market assessment. I mentioned that earlier, and it includes all of those components there. The second step is let's clarify where the organization is going to be in the next 2 to 3 years. Let's gain agreement on strategically what's relevant. More importantly, let's talk about how we're going to measure what it is that we're going to do over the next number of years. The third step is the development of the written strategic plan. And it says at the bottom, refer to the Rural Hospital Strategic Planning Template. I actually share with you it's not a critical access hospital. It's about a 30-bed community hospital. Their table of contents, I blinded their recommendations or their initiatives, but you can see what their full plan looks like. It's about 6 pages. You don't have their full plan, but if for some reason you want to see a strategic plan blinded, I can send that to Leslie and get that to you. This step 3 also includes an all-day retreat, and if we're talking about a strategic plan that looks out over 36 months, what we typically do is want to gain agreement on the short-term initiative, so that's 12 to 18 months. And when I say gain agreement, it's a retreat with board members, medical staff leadership, as well as members of the executive team. I just talked about the retreat, and you will be receiving a blinded retreat agenda. All of the materials that I send you are coming from hospitals, so it's nothing that's made up, if you will. And then the fifth step is a strategy execution workshop. That is where the management team, department directors, senior team gets together, spends a day, talks about what the board had gained agreement on, but works through a process, and you see one sample below. It says quality and customer service pillar, where they're clear about what the action item is, what the deliverable is. I also want you to see that these little blue dots, once they got a measurable and a measurement and a deliverable, they may decide that's so important we want that on the organization's scorecard. Here is an example of how you link metrics to the objectives in your strategic plan. These strategic themes, there are 2 here. The first is called quality and customer service theme. The second is a staff development theme. You can see the written objective in the strategic plan, and some of the metrics on the quality and customer service theme is this organization said they're going to achieve top 10 percentile for core measures, achieve 95th percentile for all satisfaction scores, achieve 100% of selected patient safety goals, and 0 serious events in 2012. So what you typically see, and you'll see this in the template, before the organization begins to think through what the initiatives are, let's be clear about what the theme is, what's the objective, and how we're going to measure it. The board has a minor role in setting the targets. It's management that has the more significant role. Here are 2 more themes from a community hospital strategic plan, and it's organized the same way, where we've got a set of objectives and a set of metrics. The end result of the process, the strategic planning process, is typically a 1-page board report, management report, that would have a category: quality and customer service, staff development, growth, and financial health theme, and it'd be about 4 or 5 metrics within each of those, with an associated target and some trended information. So that's what most of the small community hospitals get to at the end of the planning process. This is a community hospital from the state of California that last year needed to get a strategic plan done in 45 to 60 days. I'm not going to go through all of this, but in fact they finished it, the strategic planning process at the end of 60 days. You can see in the first phase they completed the market assessment. The second phase they completed vision as well as draft strategies and metrics, and then developed the strategic plan in about 3 to 4 week period, and that culminated in a retreat. I'm hearing less and less discussion about let's go through a strategic planning process that is 4, 5, 6, 7 months. I'm just not hearing a lot of that. This slide just points to the things that boards can do to support the strategic plan or the strategy. I'm not going to walk through the board ground rules. However, if you look at number 2, there is a way of designing the board agenda so it tracks the strategic plan. So those things that we just talked about that were the major strategic themes that came out of the plan: quality and customer service, growth and provider relations, staff development. Those are the broad categories now that are talked about in the boardroom. The other thing that boards can do to support implementation of the strategy is to avoid operational minutia. I was at a brand new critical access hospital in Pennsylvania 3 days ago, and one of the things that the CEO told me is one of the reasons why we got to build a brand new facility over the last, and they opened it up in 2007, is we spent no time drilling down. We spent no time on operational minutia, but we just spent time on the things that were strategically relevant that would get us to new site, new facility, enhanced medical staff, additional specialty clinics, and said that his board just does not spend time on things that are not strategically relevant. Here are 6 of the drivers of organization performance that came up with this list about 6 months ago. But first, the organizations do a market assessment, understand what's going on internally and externally. 2, they seem to put a stake in the ground for the next 3 years, so that they have clarity around what they want to create, what they want to do. They adopt those 5 principles of strategy-focused organizations that we talked about. They actually spend time creating a constructive culture, and if some of you want information or a definition of that, or you want to see a case study of a rural hospital that went from a dysfunctional culture, if you will, to a constructive culture, I can send you that. The other thing that we're seeing in these successful organizations is many of them work with networks of other rural hospitals to improve quality and financial performance. And then the thing that I see universally is they use metrics to create a competitive advantage, only because you cannot escape the accountability. So any other questions or comments on designing a hospital rural strategy? If not, I'm going to go on and talk about networks and share with you how to create networks and what they do to drive performance.
And if anybody has any questions, it's star pound to unmute your line.
I am going to keep going. I'm going to talk about 4 or 5 networks that I am familiar with, we have worked with. The only one that I have unblinded will be Pennsylvania, the Pennsylvania Critical Access Hospital coalition, although you will see some Indiana data, so you'll know that some of the hospitals that are in the scorecard I'm going to show you are from Indiana, but the specific names of the hospitals have been blinded. But each of the networks has an interest in what's going on nationally, okay, because there are some very good national benchmarks based on empirical data. They want to know how they compare regionally. They always want to know how they compare with other rural hospitals within the state, how they compare with PPS hospitals within the state, and then internally they want to understand their own performance. So I'm going to walk through some of these networks that I'm familiar with. This is a rural hospital strategy map. So this is a network that is on the West Coast. It's comprised of 14 rural hospitals that got together about 5 years ago in order for them to launch and understand their strategic plan. They said, can we build this thing called a strategy map so it's on one page? We can attach metrics to it, but we just want, so we can share internally with our board, with our communities, one page, this is what we do. On the left-hand side of this diagram, there are 4 perspectives. At the bottom, there's a learning and growth perspective. So that's all about the 14 hospitals, what they bring to the table in terms of facilities, in terms of people, in terms of capability. The second perspective is titled network development. Those kind of the objectives related to the network development relate to the 14 rural hospitals. The next perspective is members and stakeholders in terms of what do they want to gain. And then the fourth perspective is network growth. If we were talking about our individual hospitals, we'd probably be talking about financial performance. But to tell the story of this network kind of quickly, this network said, if we bring the right people together and we can facilitate peer learning and mentoring in an open environment and develop the best rural health care, okay, collectively we can create new relationships. If we can develop meaningful, and they said credible rural data, maybe we can improve performance. And if we can do that, we can develop rural appropriate best practices, increase transparency, and then we can implement practical network strategies. And that's in fact what they're doing. I want to talk for a minute about the kinds of emergency department data that's available across the United States, and then I want to talk about what some of the networks are doing to improve performance within, and we can send you copies of this. We looked at 2.3 million emergency department patient encounters of only critical access hospitals, and we found that the mean time the ED provider was 28 minutes. The mean time, total time in the ED was 127 minutes. One of the networks of 10 critical access hospitals that I'll talk about, they actually improved their network performance better than the mean, and you can see their data there. They had 25 minutes to ED provider and 109 minutes to total time in the ED. Now, prior to this national study, about the best we had was information coming from Presgany with their national benchmarks and the Centers for Disease Control with their national benchmarks. But what you can see is rural performance is different. The metrics are the same, but we actually outperform our urban counterparts, as we talked about earlier. In this network of 10 rural hospitals, they were concerned about the question of would you recommend this ED. The state average is at 87%, but you can see among these this network of rural hospitals, Hospital 4 is at 94%, Hospital 6 is at 97%. So when the quality directors get together, oftentimes the ED directors will attend. They talk about let's learn what Hospital 4 and 6 is doing, so we can all do not only better than the state average, but we can all achieve that 97% would recommend. This is a network of 20 rural hospitals, and they said that the project will include financial benchmarks, emergency department benchmarks, operational benchmarks. They expanded it recently in the last 18 months to include CMS core measures, the transfer of communication measures, pharmacy, HCAHPS. And this is a group of rural hospitals that gets together quarterly, CEOs, CFOs, quality managers, as well as ED directors. They typically spend the first 2 hours together understanding the performance of the network and the individual hospitals. Then the CEOs and CFOs will break out and discuss the financial performance and how you make improvements, and the quality directors will talk about the some of the quality initiatives. In some of these networks, just to go back, we work with a number of states where Blue Cross is actually funding this effort because they want to see improvements in quality over time. This same network, phase one, they're focused on pneumonia and heart failure, and here's their data. They put together it's an MBQIP network scorecard, and you can see their CMS core measures for pneumonia and heart failure. So this is all 20 hospitals, looking at the performance of all 20 hospitals. You can see they've got a target of 100%, so just like we hear from the Institute for Healthcare Improvement, they said it's all or nothing, it's 100% or it's zero, and you can see the network scores. More importantly than that, they say, let's look at the CMS core measures at the individual hospitals. Let's look at a index score. You can see the network score for heart failure is at 83%. Nationally, we're at 84%, and you can see what the individual hospitals, where they're performing at. Now, when the quality directors get together, they say, well, this is interesting, but the only way to make an impact, to have an impact on this, is we need to get down to the physician level. So they create these physician level dashboards. So at the physician level, they can begin to have a discussion of this specific physician. And if you look at pneumococcal vaccination status, the physician score is 78%. Doing better than a medical staff comparison, but still not at 100%. So they can bring these scorecards back to their organizations, have a medical staff leadership discussion after they learn network best practices, and discuss how, in fact, can we move all of these scores to 100%. So this network starts at a fairly high level. Let's look at network performance. Let's look at hospital performance. Now let's put together a physician-level dashboard, and let's see how we can gain agreement on best practices, and let's improve the network scores. The second thing that this network wanted to do, phase two, which is with what they're in now, is to focus on outpatient and HCAHPS scores. And the goal of MBQIP, which some of you are, I'm sure, are participating, is to not only get small community hospitals involved in HCAHPS and core measures, but mainly to improve quality of care. So this next network we're going to look at is a network of 16 critical access hospitals. I apologize, this is a little busy. They all participate in HCAHPS, which is not a requirement. When they look at their data, this network does very well on some of these HCAHPS survey questions, but the ones that they questioned was related to area around the room, was quiet at night, and hospital rating, and would recommend. Where the red shows up, they're doing a little bit worse than all critical access hospitals in the United States, and they're doing a little bit better than all hospitals in the United States. And the all critical access hospital, all hospital data is available publicly. They wanted to graphic and see what they look like. So if you go to the middle bar graph in terms of willingness to recommend, they wanted to see what was going on with all of the state critical access hospitals, what was going on regionally, what was going on with the state PPS, so the larger community hospitals and all cars in the United States, and and you can see that they fare pretty well in comparison. This is a network of 20 rural hospitals where they're concerned about finance at the network level, and this is fairly busy graphic, but you can see the metrics over on the left-hand side, days cash on hand, all the way down to salary expense as a percentage of total operating expense. You can see the median network scores. You can see the network target. So when the CEOs and CFOs get to come together, I also tell you this is in a state when you look at their numbers in terms of the operating margin, salary expense as a percentage of total operating expense. All of the hospitals do very well, and they have good commercial contracts. So this is a little bit unusual, but when the CEOs and CFOs get together, they'll talk about those network medium scores that are underperforming or in the red. Oftentimes a CEO or CFO will bring their individual hospital scores, talk about what they do to achieve a certain metric, and then oftentimes there's agreement on next steps and best practices. In between the quarterly meetings, there's a lot of conversation among and between the CEOs in terms of performance and improving performance. This is the same network of 20 rural hospitals. They said, they asked if we could sort this by independent hospitals, so independent freestanding, county-owned facilities, and those rural hospitals that were part of the system. And so we did that, and the interesting conclusion they came to is it looks like the system-owned hospitals do better on all of the financial metrics compared to the network average. The county hospitals do better on, it's 3 of the, I think it's 8 metrics here, and the independent hospitals that were part of this network didn't do as well as the network average. And again, the objective here is how do we improve the performance of all of the hospitals, but they wanted to know if there was a distinction by hospital type. This is the same network of 20 rural hospitals and a financial dashboard. This is hospital 246. They specifically wanted to know how they compared to the network performance and how they compared to every hospital in the United States. So this is something that each of the hospitals did receive as part of the network. In Pennsylvania, there's a critical access hospital coalition. 12 of the 13 critical access hospitals participate. Larry Barona is the Flex coordinator. This is a very mature network. They also work with the Hospital Association of Pennsylvania, Quality Insights, which is their QIO. They have Penn State grad students that come in and work with the network. They work with the Department of Health and the Healthcare Quality Alliance. They have a very simple formula in terms of how they improve, how they show improvement, and they look at on a number of indicators the numbers of hospitals that show improvement, on the denominator the numbers of hospitals that are participating, and in this case they came out with 80%, but they're more curious about what did the network do to help the cause, in this case, either improve or why didn't we help them improve performance. Here are some of the innovative products that they've launched over the last 8 years. You can see it ranges everything from something that they call Gaining Strategic Edge, where they brought the CEOs together for a year. They collectively did their market assessments, learned strategically what they could do to move market share, all the way to a pneumonia project, to a medication management project. If you're interested in starting a network, Larry Barona is a good friend. He knows how to launch and how to sustain one of these, and he can be a very, very an excellent resource. So that's a little bit about networks. I'm watching the time, and now what I'd like to do is just talk generally about how you use metrics to improve performance. The hospitals that I work with and my organization, we're a big believer in measurement. We also think that whatever you measure is what you get, and we also have a belief that if you can measure it, you can better manage, or you can better lead. So here are some key points, and anyone who wants the metric library will be sending that to everyone who participated in the call. They're rural relevant metrics where we show the numerator, denominator. So if you're forming a network, it gives you a common definition of for comparison. But some of the other key points is the metrics enable the networks or the hospital to track progress. There's clarity around the numerator, the denominator, and the calculation. And if you're working with a metric, there always should be a metric library that spells out that definition. This is a modified board report, a component of an organization's board report where this board wanted to see index scores for AMI, heart failure in Pennsylvania includes this not only on their quality report, but the state of Pennsylvania through the Patient Safety Council has a 3 indicators that roll up all of the other quality indicators within the state. This is a network scorecard, and you can tell it's in Indiana, where the first critical access hospital network number 1, the second critical access hospital number 2 wanted to compare their performance within finance, quality, HCAHPS, and market, meaning percentage of population over 65, Medicare market share. They wanted to compare their network performance to the state of Indiana, to all critical access hospitals in the United States. And where you see the critical access hospital number 2, the green scores, that's a network that does outperform network number 1 because they do better than the U.S. cause as well as the state cause. So let's just briefly talk about what a strong hospital is. Many of you know that we came out with a rating and a ranking system for the top 100 critical access hospitals in the United States. We made that public a couple of months ago. But here's the definition of a strong hospital, regardless of size. And there are 3 perspectives here. One is a market perspective. And what we see in the United States in this study group of about 4,600 hospitals is that those stronger hospitals have a dominant market share, okay, when we look at Medicare or all payer share. So greater than 50% would be dominant. A growing demand. Growing demand means if we look at the numbers of inpatients, outpatients, by visit type and demand over the next 5 years, or the 5-year projection, that's not flattened down, but there's growth there. Strong hospital has diffuse competition, so not as many competitors within the marketplace. Strong hospital has outstanding quality and safety programs, loyal, satisfied patients as measured by HCAHPS and satisfaction scores, and then financially have a strong income statement, balance sheet, and high margin services. And I'm not going to go through each one of these slides, but I talked about the index components that we use for this measurement tool. There's one related to market strength, one related to value-based strength, and one related to financial strength. We look at 56 indicators for all 4,600 hospitals, and I'm not going to walk through the methodology, but you can see, for example, within market strength, we're looking at things like market share. We're looking at market growth. Within the value-based strength index, for the quality index, we're looking at all of the process of care measures. In the outcomes index, we're looking at outcomes of care, readmission rates, mortality, scores for AMI, heart failure, pneumonia. We're looking at all of the AHRQ patient safety indicators, composite scores. So a fairly sophisticated analysis. I'm not going to walk through each of these, but I want to show you some comparative information, and then I'll just open it up for for a question. This is the kind of comparative information that many of the networks will use. So, for example, you see at the top left here, it's got your hospital score. So it's got your overall hospital strength index score of 76 with a financial strength, a competitive strength, and a market strength. And you can see who within your network, or even in a competitive basis, who's in the top quartile, who's in the second quartile, who's in the third, and who's in the bottom quartile. This is a network that we work with, where they wanted to look at compositive hospital strength index scores, but they also wanted to compare themselves with within the state the PPS median scores, all of the CAR median scores, as well as all of the state median scores. And then finally, this is a piece of a network scorecard, and if you look, you can identify the state that I'm talking about. But it's got the hospital strength index quality scores, but as importantly, it's got out migration using the CMS Medicare inpatient file. So for example, this network wanted to know of the Medicare patients within our service area, what's the contribution margin that's leaving? And in fact, if we could take care of these patients and it were appropriate care, so we're not doing cardiac surgery or neurosurgery, but things are appropriate in our rural community hospital, what's the pickup in terms of the Medicare contribution margin? So this network actually said, if we could turn around this out-migration for these numbers and kinds of Medicare patients, here's the millions of dollars of pickup. So I do see one question there, and I should have mentioned this, but there's a question about what's EBITDA. It's a financial metric. It's earnings before interest, depreciation, and amortization, and it's just a way of looking at profitability, but mainly cash, if you will. The other thing, when we send around the metric indicator library definition, you'll get definitions for all of these terms as well as the calculation. So I went just about an hour. I feel a little bit like the Federal Express person, but if there are comments or questions or suggestions, I'm very open.
Hey, Scott, this is Bethany. Can you hear me?
Hey, Bethany.
I just wanted to share, we have some great feedback from some of the REP reports, the recommendation, adoption, progress reporting, where we follow up with the projects, these types of projects, and very specific answers from administrators. For example, just to share with some of the folks on the call today, and again, I contribute this back to your coaching and your process and these types of, get the hospitals really thinking about the specific outcome, but and it's across the board, but here are just a few real live examples. HCAHPS reached a goal of 7 out of 10 to be the 90th percentile. I mean, they are very specific in that as well. Actually, increased financial, bottom line by $1 million for that current fiscal year that you were working with them. Days cash on hand went from 4.5 to 56. Patient quality outcomes 95 percentile, then da-da-da. And the one thing when we follow up with these types of report projects, just love the fact that the outcomes are very specific. So that's going to be even more important, not just for RHPI, but all the programs as we move forward. So.
Yeah, and I think as we hear, and Terry knows this better than me at the federal level, is there's a real interest in performance and metrics and outcomes. And I when we did the urban versus rural study, we didn't know what we were going to find, but You know, that's empirical data related to outcomes for small community hospitals, and the performance is better than their urban counterparts. So, and Bethany, the credit goes not to me, but it really goes to the executive teams, and it goes to the department directors and board members that work in these small community hospitals that get these kind of results. So, yeah, it's very encouraging.
It is.
Well, thanks for the comments. Other comments or questions or thoughts? Again, Leslie will be following up with the additional materials that I talked about. I also have a blinded strategic plan of a county hospital, and we blinded it where we don't think that you can identify it. And if you want that, and it's got the market assessment and their recommendations, and if you want to see that, it's about 35 pages. We're more than happy to send that to everyone as a PDF. Just let me know, or just let Leslie know. Any other
sharing all that? That's great.
Okay. Well, look, if I don't hear any more questions, we can get done a little bit early. I think that's always a good thing. But I appreciate your attendance, and appreciate Leslie's help and support. And if there's anything we can do to help, just let us know.
Thank you, Scott, and have a good trip as well.
Okay, thank you. Yeah, I'm going to Chicago in a couple hours.
Oh, yeah. And Debbie Robbins says it was an excellent webinar. Thank you.
Well, thanks so much. Appreciate it.
Yep. And
yeah, bye-bye.
Everybody that's on the line, we have the upcoming HELP webinars include Scott's next webinar, Linking Strategy to Operations to Achieve Great Results, and that's next Wednesday. The next upcoming webinar is in June, and that's Medicare Payment Issues for Small Rural Hospitals by Tommy Barnhart of 10 Mile Enterprises. And to register for any of those webinars, you can follow the link on the bottom of the screen. And we'll also be posting the playback of both Scott's webinars after they are completed. And if you would like to receive ACHE Qualified Education Credit, you do need to take the online Zoomerang survey. And the link is on the screen for the Zoomerang survey. I'll also send it out via email to everybody that's participating today. And also I will be sending out all of the documents that Scott mentioned today in that email as well. So I just want to thank everybody for participating. And if you have any questions, feel free to contact me. My email address is on the screen, or I can put you in touch with Scott too if that's who you have a question for. So I look forward to seeing everybody on future calls. Thanks.
Hey, thank you. Bye-bye.
Bye.
Thanks, Scott.